So I'm just going to introduce myself, and then I'll let you introduce yourself, and then Joanna, you can introduce yourself. Then um, my name is Dr. Susan Swem. I'm Executive Director of Now We See a Person Institute, and we're an institute that helps what we call the underserved population heal from trauma. We work in a way that we help like the system, the family members, individuals be able to recover from the diagnoses that they were given, the symptoms that they had, and really what we're calling finding freedom, being able to live a life that doesn't include really any type of services, where they're kind of able to move on from that. And so I'll let you go next, Rod.
I'm Rodrigo Nardi. I'm Dr. Nardi, if you will, or Rod. I'm a psychiatrist. What else? I'm a host of a podcast, and that's about the size of it.
Wonderful. And Joanna, did you want to?
My name is Joanna Bukins. I'm a licensed therapist, and I've been working with Swim for quite some time, and have known personal people who've been impacted by difference for mental health.
Thank you. So one of the things that, there we go. Okay. So we have someone joining us, and then after that, I think I'm going to close us for anybody extra to join us. So we just have Ashley, who's just arrived. And hi, Ashley, how are you?
Hi, I'm doing great. How are you?
Good. No, long time no talk to, right? So we were just introducing ourselves. So now I'll let you introduce yourself. And then I think you're going to be the last person to join us. So this is going to be a nice, intimate conversation. Would you like to introduce yourself?
Yes, of course. Here, I can take my camera on, or turn my camera on. Hello, I am Ashley Lopez. I'm a recovery consultant with Now I See a Person. And I'm excited to be a part of this conversation to help raise awareness around mental health and expand the conversation on how we can be more supportive humans for each other.
Wonderful. Wonderful. Thank you so much. So we started doing a recovery consultant program last year. And so we've put together something for people who have experienced some of the things that our clients are currently experiencing, that they are being certified, and they will be working with us on different types of cases. And I think that's going to lead me into what I was just talking about a few minutes ago. So we were talking about that, how sometimes it is very easy for parents to find themselves in kind of critical decision making when they have a lot of providers that are involved with their treatment. You know, I think for the providers, it's something that's very normal, but for the parents, it's something that's very life-changing. And for these parents, the life-changing that happened to them kind of up to the whole apple cart, so to say. Like, it was a time that they experienced probably the lowest levels of being together and of being able to collaborate, because they each had like individual therapist and family therapist and all sorts of different types of classes and couples therapist. And so you just had a lot of, as my grandmother used to say, you've got a lot of cooks in the kitchen. And so, and nobody's talking to each other. So, for example, the kind of work that we do, if Joanna and Ashley and maybe David and I are working together, then we're all, of course, consulting with each other. We're all on similar pages. And when you have a lot of people that are trying, of course, to be extremely helpful, but they're all coming from different ideas, the parents, I think, get very overwhelmed and very frightened. And their natural ways of parenting with their heart or becomes something that they kind of forget about because they're trying so hard to obtain these skills that they're being told to do by all these various professionals. But one of the things it reminded me of, so this little guy read a poem to me about his time spent and what he calls confinement. It was very interesting. And it reminded me of one of the first conversations, Rod, that we had together with Megan, and where you talked a little bit about when you were, I had always kind of envisioned that you were either in a fellowship or you were, I'm not quite sure what you were doing at that point in time. You had already been a psychologist, you had become a psychiatrist, but I'd gotten the opinion that you were still in training because you were talking about the other residents and things like that. But where you'd hear the story of some of these children and the story didn't sound so bad. So I don't know if you would like to talk about that a little bit, because that just fit in like a glove with what I heard this morning from this kid.
Yeah, I think if I remember, our conversation was about, you started this conversation saying that, you know, schools have these professionals, and I think there's so many things here to talk about. So I think the experience you're mentioning was when, during my residency, we would receive these referrals from schools. And so I would shadow a psychiatrist that was, you know, specialized in kids. And it caught my attention that I never saw a diagnosis of ADHD being ruled out, not a single time. And I was a funny thing. I was talking today about it with my analyst. I was a pretty savage kid. I was really a savage kid back in my time. And if I were to give you some of the details, it would, you know, get anybody concerned about it. But suffices to say that once I became an adult and I saw one of my fourth grade teachers on the street, thinking I would approach her and have a conversation, she crossed the street. She went to the other side. She didn't want to talk to me. And so I think she was still healing. But anyways, so I used to see these kids with my attending, and then, you know, the kid would leave, the parents and stuff, and he would say, "What do you think?" And I would say, "The kid's is fine. The kid's fine, right? The kid's absolutely fine. You know, I have seen worse. I was worse, but I was not aware then. It caught my attention, and I didn't have. I was still in the compliance training that residency and medical school should be, right? It's a compliance test. My critical thinking was knocking on the door, but I wasn't giving it too much attention. But it sufficiently that I said, wow, I never saw a kid not have ADHD. You know, if a kid makes to this office, he will be diagnosed and he's going to be prescribed a stimulant. So that, I think, is the story that you're mentioning. I never saw context being taken into account, because really psychiatry has become, or in general, mental health has become this checklist diagnosis. And that's why, for example, I don't refer anymore for neuropsych testing, because unfortunately, the same biases that we have in clinical thinking nowadays are present in neuropsych testing. So neuropsych testing used to come back negative every so often. Now everybody has ADHD. Every single kid out there has autism, apparently. You can't be weird anymore. You cannot be a little bit more active, you know. If you cause problems enough to generate a complaint from a teacher, then you're going to receive a diagnosis, and this, you know, medications, and which we don't know a lot about what they do in the long run, right? We know now they cause atrophy of some parts of the brain that are associated with motivation. And when I see young adults these days, I think, of course, we are living in a world where young people have nearly no chance at achieving the things that their parents and parents achieved at the same age. Economy is ruined. The government, as we were talking 5 minutes ago, it feels the government is against us. But I also ask myself, is this the effect of suppressing their emotional life? Is this the effect of, how many of these kids have been exposed to stimulants right now? What are we looking at here? Is this going to have an impact at a, let's call epidemic level, considering that we have 80-something million Americans taking some sort of psychiatric medication, right, that we know very little about. But I think that was the story. I digress. Back to the story. I think that was it, right? Without looking to the context, without ever diagnosing a trauma-related presentation, every kid would be diagnosed with ADHD because we don't have means to rule out situations like that.
And when I thought about this young man who is, I met him for the first time last night, who is obviously very talented, very intelligent. One of his parents is a educator of some type, and the poetry was just amazing. And this is a young guy that talks about basically his rights being taken away, him all of a sudden not knowing if up is down and down is up, and where he has been left voiceless. And again, this happened accidentally, because I don't think that looking into the context of situations is something that practitioners of any sorts are being trained in looking at. That is almost like an old-fashioned thinking. And I thought about that too after the conference, because when we started calling this Now I See a Person Institute, I think everybody knows it was because I had a student at a university that I was teaching at. She came in one day. She said, I hated my client. I said, what do you hate about your client? She said, I don't know. So then we had a conversation about what happens if you don't like the person that's in front of you. That is, it's not that person's unlikable, but what are you, quote unquote, projecting? What kind of prejudice are you projecting onto them? Like, are they not doing what you think they should do? Are they reminding you of somebody? Are they not politically correct? There's a plethora of reasons why you may have this flash judgment. So she came in the next week and she said, the client that I hated is now my most beloved client. And I was like, oh my gosh, we've got to get this on tape. And I was doing research then with an institute in Cananquil, Mexico. And she said for the first time in 10 sessions, she left everything that any clinician had said about this client outside of the door, because this is one of those chronic clients that gets a new resident or a new mental health worker in some way every couple of months, but probably does not have the means or the courage to do something different. And so she left the progress notes outside the door. She left what people had said verbally outside the door. She left all the notes and the treatment plans and the testing and all sorts of things outside the door. And I am going to admit just one more person. And so what happened was, then she said, for the first time in 10 sessions, I saw a person. I saw why she wasn't following the treatment plans, because they were my treatment plans. They were treatment plans of other people. They weren't hers. I could understand those moments of suffering that she had and why she did some of the things that we considered that she shouldn't be doing. And so it allowed her to have a different relationship where the context did come in, because she was able to listen. But if you're so worried, if you're doing things in those conforming ways, then it's hard to listen. And so I think that's what I hear a lot, especially with this person I'm talking about, not only the person of, that described now I see a person and we coined that, but I was thinking to myself, is that still something that people see that's valuable? Is that people do have a voice, that there is a context? Because people are so being trained and not really following those types of things, and not following their instincts, but really following a very rote way of going in and applying something to every person that they come into contact with.
Yeah, I think modern mental health is sort of fostering a model where context doesn't matter, right? So if I see you do A, B, and C, and I have a little book that says that A, B, and C should receive this stamp, the reasons really don't matter. I remember I had a conversation with a and there's a fair amount of division about it, but it's a problem that is not addressed. I was seeing a patient who was doing chemotherapy, and that was also during my training, 2013, 14, something like that. And so if you're doing chemotherapy, then you're tired, and maybe you can't sleep very well, and you can't enjoy things, and you're upset, and your appetite is crap, and okay, you meet criteria for major depressive disorder according to our little book of rules. So I go and I talk to my attending. I say, oh, obviously I'm not going to offer an antidepressant, because the data in reality, which exists, shows that we're not going to make any dents. And he said, well, why? And I said, because this is a chemotherapy thing, and this guy has cancer, and he has plenty of reasons to be upset. And he says, well, but you see, diagnoses don't take into account that. While another attending that had more critical thinking said, well, that's not exactly what we're thinking depression is. He was kind of agreeing with me. Now comes the bad news. The bad news is that for both of them, is that, so what is it that we're thinking depression is? Is this magical entity that is spontaneous, that someone is just sad without any reason? Well, it turns out that if you put aside, because we have a lot of difficulty doing that, which is inherent to the task. And the difficulties we have is, someone is telling me I'm feeling sad, or I can't focus, or I'm feeling whatever. Okay, now I have to say, okay, let's find out why. Mm-hmm. Now, we're not very good at it. People are not very good at saying why I'm feeling this way. We have all kinds of values coming and playing confounders, I would call, right? The more we take biology into account, I think the closer we get to the truth. But and that may allow a few inferences, but for the most part, it's a discovery journey. And it's a discovery journey that we like to believe we're helpful in it. But at the end of the day, as I always joke with my patients, you do the heavy lifting, I'll take the credit. Because the patient, it's his journey of discovery. And our job primarily is to say, I don't buy it. I don't buy that you are feeling sad for no good reason. And then we have to do this attempt that may fit a psychological theory, or may fit all of them, or some of them, or just a hint. It's because it's an artistic endeavor. But we're trying to say, okay, if I put myself on your shoes, with my traits, with my biases, with my history, can I identify a reason to be sad? And if you say yes, well, good, because we people do have enough in common. But if we only do that, then we have a problem, because we also have a lot that is not shared. that is, belongs just to your history and just to my history. And this way of working that we have nowadays, okay, you tell me what you're feeling, I'm going to give you a stamp, and from there we're going to choose a treatment, doesn't favor discovery, the insurance, the paperwork, all the things that were supposed to be means to an end, they become the end. And as long as I'm sending a billing code and filling enough words in this damn piece of paper, everybody's happy. And I'm doing my job, because now my job is to say what you're feeling, this is the drug, and this is what I put on paper, as opposed to say anything that is deeper than that, to say, okay, there's a human being in front of me. And as far as I'm concerned, every human being is a miracle, at least a statistical one, right? If you don't want to go into a religious approach, we can just say every human being is a statistical miracle. It's a collection of unlikely events that took place for that creature to be sitting in front of me, and it has an inherent beauty that deserves to be celebrated and lived, as opposed to suppressed. Mm-hmm. Right? So if you're miserable, hey, there has to be some legitimacy about what you're feeling. Yes. What can you do for you? As opposed to say, no, I think you should be happy where you are, or at least you shouldn't be feeling so much. And guess what? I have some resources for that, So that's where we find ourselves. And yeah, you start saying these things in some places. Oh, Rod is very controversial. Is painfully obvious.
So where would people say those types of things?
Say that again. You broke a second.
So where would people say those types of things to you?
Oh, what context?
Yeah.
Oh, everywhere. Every professional. Now I'm because of my private network. I found a way of selecting professionals that can actually speak this language. So, I'm slowly getting less and less patient with the folks that cannot speak that language, because it's easy to get used to good things, right? And then that becomes your new baseline. But yeah, I have a group of professionals that are joining my network, and we meet every Monday to cover this psychotherapy things and paradigm that we're going to use for our work. But everywhere else, it can be in a hospital, it can be a staff support, it can be nurses in the hospital, it can be psych nurse practice, it can be psychiatrists, it can be people at my place of employment, where we are a mental health profession, where if I say the context and the experience matters, people look at you as if you're losing your mind.
Yeah.
So what happened to us, right? Look at the history of psychology. The ability that, let's say, Freud had with a handful of patients to write 24 volumes on human behavior, with a handful of patients that Jung got to write so much and experience so much and dig so deeply into things. And then Skinner, without ever talking to a patient, was able to have a depth that we don't have nowadays, able to entertain problems and limitations that looking at human behavior have. And then Maslow. And what happened to us? What happened? I mean, look at what we were doing. We're peeling this onion, and every time you're peeling an onion, there's no two onions that are the same, and yet there is a progression. There's a learning. There's this ability to tolerate uncertainty and the flexibility that comes with not knowing what you're looking at. But no, all over. This is over. We have this diagnostic system that was born exclusively in hopes to unify research language, and then all of a sudden takes over reimbursement, takes over diagnostics, takes over the therapeutic interventions, And so it's really everywhere. We can feel in the air that it's changing. Just the fact that we are here having this conversation is very meaningful. And it's changing. And one of the reasons I believe it's changing is because lies do need advertising, but the truth always is, all it has to do is sit there and wait. So eventually people are coming on board, and I'm seeing that more and more. But yeah, every environment, I cannot have these conversations. Let's say I'm going to change my place of employment, right? You got to be very cautious the things that you're saying. And I can throw a book at people because I'm a nerd, and yet, there's this simple choice of saying no. And I saw that happen a lot. Like when data is not sufficient to make someone change their mind.
It's interesting. I think I might have mentioned this, but maybe I didn't. I mentioned it to somebody else, I think today, is that I had a conversation with somebody that had been hired by the insurance companies, by the government, by whoever, right, to try to standardize care, right? So that was their role. And they're not a spring chicken. So they've been around for a period of time, like I have, because prior to the 80s, things were not biological, right? And so all of a sudden you see all of these diagnoses or treatments or whatever. Medicine was meant to go off and on, right? You would put somebody on it maybe in times of stress, crisis, again, following the context, right? If we're looking at, Hansel and Gretel. And then all of a sudden, everything becomes biological. And I remember for us as clinicians, we were really surprised that people bought into it, because we were thinking that it would be a hard sell because it wasn't advertised. You didn't have, that was also about the time that they started building a lot more hospitals. And so, you'd see these kids that I used to say that looked like young Republicans at that point in time, right? So they had, this was a time, where people were probably still looking kind of straggly here in the United States. So you would have these hospitals of the kids that looked kind of scraggly coming, walking into the hospital. These were the commercials, and they'd come out like being a young Republican with their arm around their mom and dad and all of these types of things. And through the advertisement, through word of mouth, through professionals now instructing them in a different language of change, that the whole avenue of how we approached seeing people changed. People were no longer seen as people. They were seen as biochemical problems. And so you could have people that were in all dastardly types of situations. And that wasn't, it might have been addressed in the first session, but once that diagnosis came into play, there was no room for it whatsoever. And I guess that, again, being someone that was around before all of this happened, is that the amount of negative consequences seems to be increasing more so than you saw before. Would you like to expand on that?
I think I did not see that transition, but I got to learn from a lot of people who did see the transition, and that's on account of my podcast. I didn't have attendings that quite saw the transition, and the ones that I had that saw the transition actually profited tremendously from it. So from doing finance research and things like that.
Mhm.
But it's just the reductionism is terrible, right? And now the level of absurdity of the thought process is striking. The level of absurdity, it's like it does feel like everybody went mad all of a sudden. And I understand how it happens, because we are losing the bridge with those days, right? One of the guys that I interviewed was Dr. Bellmaker, and he just published a beautiful book called Psychopharmacology Reconsidered, where this guy, he was doing research in Israel about, let's say, olanzapine. So he would take olanzapine.
Wonderful.
Right, he would do research on Haldol. He would pop a Haldol, and he told me in the interview. He said, "I was suicidal for 2 days. Myself and my lab colleague, the guy that was researching with me, we were like having suicidal thoughts. We're miserable, and we asked ourselves, wow, why these medications have such a But even if we detach from the medication, I think if we just look into this approach that you mentioned of this person you met, where how can we standardize treatment, right? I think the idea is a valid one. How can we use what works and discard what doesn't work? So, okay, valid. Let's look into this thing. Well, we have been doing that now for virtually 40 years, 30 to 40 years. And the results are nasty.
Mhm.
They did not result in any money saving, as someone would hope. If anything, the opposite, because you see, I used to say this before. I used to say, the career of a psychiatric patient never ends, only starts. I never saw, until I started this journey myself a few years ago, I never saw a patient come off medications and say, God bless, go live your life.
Mhm.
No. Why? Because we have all these ideas built in. One of them, for example, is that depression is recurrent.
Mhm.
It's not that you are sad again because life sucks.
Mhm.
Is that this entity, this magical entity called depression, was sitting quiet in your body, just like lupus or rheumatoid arthritis can be quiet, and then you have a flare up. So it's recurrent, it's coming back, it's the same problem coming back. And if you have, this is an interesting piece of information. And this is where we see how everything's, the contamination of our field comes from everywhere. And that's one of the reasons I stay out of politics. It's because I have a very clear picture in my mind of how both sides of the polarized field were used for maneuvering to destroy what we have to do and still, result in, profit. The field of psychiatry itself, 76% of psychiatrists in America are Democrats, but they have no problem whatsoever in practicing a psychiatry that is run by pharmaceutical companies, right?
Mhm.
So clearly, ideology is not going to save us. But what I was trying to say is that the complexity of the thought was subtracted, and now we have this idea that, okay, we have this entity sitting inside of you, so you pretty much have to take these medications forever, and the cost of that. So it failed. The attempt to let's say, divorce from complexity, the attempt to divorce from the richness of human experience, failed
Yeah.
miserably. And under whatever parameter you have, we're not saving money. We have more diagnoses, we have more treatments, we have more side effects. Antidepressants, we thought they were safe. Now we know they cause diabetes, which, more medication on board, more treatment, more chronicity. And And the struggle of being a human being, no, there is no struggle. If you have one, you're sick, right? And now I have patients leaving America and going back to, like, legal immigrants going back to Puerto Rico and Dominican Republic because they cannot afford life here anymore. So I should give them a diagnosis of depression, I guess, because they're feeling sad, or maybe they are becoming phobic of homelessness. I don't know. It's just insane. The level of insanity that the field, the mental health in general, has embraced it's a collective hysteria, if I may diagnose it.
Mm-hmm. Mm-hmm. And, again, I enjoy so much these conversations. I hope to have so many more of them. And I'm going to include our two panel members in just a second. But, it's gotten kind of to the point that you worry about people that are going in for services because the context is not going to be looked at. The voices aren't going to be validated, and people are learning a new paradigm for what's happening to them. People start to believe that they are the diagnosis. And one of the things that we realized, of course, this is the way that I was always trained, but one of the things I realized about almost 20 years ago is that the people that we saw, when they did not see themselves as a diagnosis any longer, had rapid healing, incredibly healing. It was like almost like a night and day kind of thing. And the people that continued to see themselves as having this biological entity within them that creeps out every once in a while, under stress, even though it shouldn't, because they're being medicated, right? But somehow that medication is saying that should be handling everything, divorces or, all sorts of tragedies from happening. That those people are more susceptible to wanting to harm themselves. So you have people that are either thriving in what we kind of call finding freedom, or you have people that are becoming much more desperate.
Yes, yeah, because obviously, I think two factors here. One, as I was going to say before, and I got lost in my thoughts, is if you take the World Health Organization, which is a heavily politicized institution, they define health as a complete state of well-being. So I don't know anyone healthy, for starters. And if you have a diagnosis of depression, and every time you feel sad now, it's the depression coming back. So that idea of a mental disease. And then you look into tools like PHQ-9 and GAD-7 that, at some point, hopefully, were well intended as screening tools. Now they became diagnostic tools. Not surprisingly, the copyrights belong to Pfizer. Because as long as you answer one of those, if you have a bad day 2 weeks ago and it was miserable enough for you, you're going to come up with a diagnosis. So now we have all this context, and then we have the work of therapy, that is to find the truth. And this person sits in front of you, and I still have very visceral reactions to this when someone says, "Well, I've been sad," and I say, "Why?" And the answer is because of my depression, which is the same as saying I am sad because I am sad. And then now I have to dedicate the work, the precious work of therapy, to just clarify that you are sad and because of your depression is the same as saying it hurts. I feel pain because it hurts. So and once that, because we are meaning-giving animals. We give meaning to everything, right? And instead of looking to the right questions and looking to the whys of our experience, now we have an answer. So, I saw on TV is because, and I checked on Google, I saw all the symptoms and I checked all the boxes, it's because I have this thing. Now the search has stopped. So the very therapeutic work is dead on account of that thought process. It is your depression. It is your anxiety, as if it's an entity of its own, as an entity without a purpose, I think, which is the most important part, because we don't feel things in a what's the word in English that I don't want to butcher. There's no gratuity to what we feel. Mm-hmm. There's a purpose to our emotions. We're well designed like that, either by evolution, by the creator, whatever you are into. But yeah, of course, it makes complete sense that once the label is dropped, that's when the quest starts. That's when the therapy actually starts. It's just sad we have to go through that before anything happens. But once the questioning starts, per se, it's when improvement starts, when change starts. Because now it's no longer, oh, you know, I have an amputated leg, that's why I cannot jump any higher, right? Well, it turns out your leg is there, you know, and you can't jump any higher. So it's not an entity, it's an experience, it's a functional, is a transitional thing. It's a, most of the time is a temporary thing, but it makes complete sense just from a logical perspective. Once you drop the label, that's when you actually start answering questions and making changes.
So I'm going to ask both Ashley and Joanna if you would have some, and there's no rhyme or reason to who goes first, if you would have some reflections on what we've been chatting about.
I mean, one of the questions I'm always pondering is how to bring about change. We have recognized there's a problem. So what's the solution for this? How can we talk to therapists? How can we talk to the clients? You know, when we're going against the grain a bit, what can we share with them to give that, like, what's our solution for them? So I guess it's a hypothetical question.
Who's gonna dare say anything about it first, right? Yeah, that's the challenge. I've been facing that, Joanna. I started a mentorship program a few years ago, and one of the things that I've noticed is, and I tried different formats. This is an interesting take. I said, okay, I'm going to just find a group of people and do a pilot, and I'm not going to charge anything. I just want to see what I have in my hands. And but what I was doing was I made a strategic mistake, because I think I was trying to vent my frustration, institutionalize my frustration, I would say. So what I did was I generated a lot of anxiety on people, right? I generated a lot of anxiety, showing the don'ts and the absurdities of the field, because they just got out of training feeling proficient about this thing. You know, it's like to say that you're an expert in Lord of the Rings. You know, it's all a made-up story. As metaphoric as it is about the World War II, it's a beautiful story, and you can see all the metaphors. It still is a made-up story, right? There's no real events taking place there. So you're a specialist in a delusion, right? So I was generating a lot of anxiety, and people were freaking out, of course. And I would face this kind of this interesting reaction. I'll give you one example, a very real one. You take a medication like Lamictal that everybody takes nowadays, right? I think we're the four of us are the only ones not taking Lamictal in America. Everybody else is taking. So, and it's approved for one very specific thing, that is depression, bipolar depression. And that's it. It's not it failed trials for mania. It failed trials for major depressive disorder in the absence of episodes of mania, anxiety, failed everything, was approved just for that. Now, the beauty of it is FDA takes only 2 studies. If you have 2 studies that are positive, you're going to get the label, the approval, regardless of how many were negative. Okay, so Lamictal had 5 randomized controlled trials for that purpose, depression of bipolar, and failed 3, succeeded at 2. Some people claim he failed 4, but 1 was kind of wiggled. I don't care. Let's say failed 3, succeeded at 2, which means pretty much we're talking about chance. It's like throwing a die 6 times and saying eventually it's going to hit 6. So you present that information to my colleagues, and at the end of that presentation, they say things like, and this is a real experience, they said, but I like Lamictal, and we'll continue to prescribe, which means it's an intuitive practice. So I was venting to Hayes, Stephen Hayes, acceptance and commitment therapy. When I interviewed him, I was venting to him about this kind of problem. And he said something very interesting. He said, Rod, if you give the path instead of focus, basically he was very gracious. He didn't say with those words, but I'm going to translate, right? He said, if you show the path instead of showing where not to go, you show where to go, people will embrace it. And it took me another 2 years or 1.5 years for that to sink in. And I think the answer is that, you know, our professional colleagues are people, and they do have struggles. Like in my personal professional life, I never met a colleague, because I asked this question hundreds of times, would you take Seroquel? And 100% of them said, I would not. Yesterday, I was talking to a group of professionals that are joining my network. They are special folks. They are different. They are at another level. And I was asking if, because we don't know, for example, let's take bipolar disorder, mania. Let's take mania, the experience of mania, whatever that is. Research on mania says you're going to find research saying that they found 0% of the population studied that had just 1 manic episode. And other papers will say up to 50% of the population they studied had only 1 manic episode and nothing for the longest time. They followed them up, like years, right? Maybe a decade. So it goes from 0 to 50%. We don't know the natural history of mania. You may have 1 manic episode and never again, or you may have 1 every 2-3 years. So I presented this question to them. I said, if it was 30% of people would have just 1 manic episode, and you had 1 manic episode, would you start taking chronically lithium or Depakote or olanzapine? And they all said no. And I said, okay, if it was 20%, 2 out of 10 people that go through mania will only have mania 1 time. Are you going to put your faith after your first manic episode that you are that person, you're not going to take it chronically? And they all said, I would not take it chronically. Then I said, what if it was 10%? What if it's 1 in 10 people that go manic will go manic just 1? And I'm talking about intermittent madness, not mania, kids fighting with their parents like nowadays. I'm talking about the good old diagnosis of mania, when people, cyclic insanity, right? You had 1, if it was 10%, 1 out of 10 people go manic and never again. Would you take medication, knowing that likelihood is you will have a second episode? They all said, no, I would not. And then I say, okay, what if you already had 2 episodes? Let's say you had 2 episodes in the last 5 years. They would still consider alternative options. So you see, there are people. Granted, yes, this is a biased sample, but the idea I think that we can try to follow, Joanna, is appeal to their humanity, not asking them to be empathetic, not asking them to see people as people, but to say, how do you cope with your pain? Every time you're sad, do you know why you're sad? Every time you're stressed out, do you know why? You know, and how do you do that? Because we are all trying to heal ourselves. And most of us are not going for benzodiazepines. Most of us are not going for Seroquel or quetiapine. Most of us are not taking lithium. And yet our patients are still accepting when we offer. So, you know, we're not sharing what we know about these drugs if we decline and they take, right? So I think one way to do this is to say, look at your experience. You are a person. You have all these things going on in your heart, in your life, your emotional life. How do you get out of stuff? And it may fail. I think the strategy on account that we may be looking at adaptability, right? One thing about I think Ron Bassman said that the more obstinate, the more resistant, the more attached to yourself and life you are, the more you're going to be a problem as a psychiatric patient, because you're not going to conform, right? And this is what we're talking about. We're talking about conforming to life as it is, accepting as it comes, being flexible, negotiating the impossible complexity of living in a society. No way around it. That's all we can do. Not surprisingly, about 2% of us just break up with reality and end up going psychotic. We say, no, thanks. I appreciate. Keep your reality for yourself. I'm going to leave my own. But you know, how I think the answer, I think we have a shot at considering what Hayes said, that is, look and show this is how we can do this thing. This is how we can do this thing. But we're not going to find a lot of echo, even like that, I think, because, you know, I am trying to buy a car and my son is going to school and I have to see 4 patients per hour and I just need to bill. What do you want? Benzodiazepines? Just give them the damn benzos. What if, you know, who cares if they get addicted? Everybody will anyways. And, you know, so we are also fighting this nihilism where and that's why I'm not a big fan of social constructivism, is because we cannot make everything relative, because it's not the same as saying you have your own experience and it matters, your life and it matters, you are unique and it matters. It's not the same as saying there is no reality, there is no truth. It's not the same thing to say, yeah, everything is relative. Because, you know, when we relativize things, then sending 18-year-old children to war becomes reasonable. And then we lose the sight of the absurdity of things, because we lose values, we lose, and you see, so there are some things, and I have been looking for a word to replace the word sacred. I'm looking for a secular word for sacred. There are some experiences that are sacred. The emotional experience is sacred. It's the human experience is sacred. We should not just suppress this damn thing left and right? Because God forbid we were all adapted. God forbid we were all well adjusted and all the same. You know, God forbid we're all just buzzing our hairs, because what's the point of putting any energy into looking good when you have hair? You should all look like me, you know. So do you see what I'm saying? This relativism comes with uniformity, not with personal freedom, as we would like to believe. So it's a complicated matter, but eventually we win, Joanna. Eventually, these ideas will continue to spread. They have been spreading. And the reason I think is that, you know, we had biochemical imbalance, then now they're talking about brain metabolism is the new buzzword that they're trying to sell. TMS has another argument. I forgot what it is. Oh, neuromodulation, right? So as we all we have to do is sit on the truth and let it slowly move forward, and let them come up with new lies to fight it, and let them spend the money on the lies while we just sit on truth. And everyone that crosses our path and is able to see it will come to a better place, you know. So I think what I'm trying to sell is hope, but not a blind one.
Mhm. So I think one of the things that we've always talked about is that we try to plant seeds. We can't go in there and change the farm. We try to plant options. And and I thought maybe Ashley, you might want to talk about that a little bit, because I'm sure you have a lot of things to reflect upon.
Yeah, thank you for opening that up for me. Um, yeah, I definitely think that planting seeds of hope is really valuable in a world where, you know, psychiatry kind of places this idea on people that, oh, there's no hope, might as well numb it. So sedate yourself and enjoy the high while you can. When in reality, there's beauty within all emotions. Like you were saying, the human experience is sacred. It's all beautiful. I like to view it from a lens of an artist. Like, not all art is the same. It's all different. Some of it's gory, like Caravaggio, or you have something really abstract, like Picasso. You have John Pilchuck, who creates something that looks like a toddler did it, but it's still all beautiful within its own way, and it's an expression of someone's soul. And by normalizing the conversation around mental health and saying, hey, friend, I see you, I see you're suffering, like we can journey through this together, is revolutionary. Like we are supposed to be sentient beings, and there are things that are supposed to settle us. Like, it was crushing to my soul when my grandma died. It was crushing to my soul when I went through my first breakup. So of course I dealt with a lot of emotions, and, you know, was looking for different ways to cope that are quote unquote unhealthy or, you know, inappropriate behavior, but it's a part of the experience and the journey. And on the flip side of that, of course, you know, when I was studying in Europe and got into a gallery, I was overjoyed, I was enthusiastic, I was so excited and vivid with just passion. Like, that life is supposed to be felt, and it's more beautiful like that. And we should just help guide our other friends in the journey of, like, okay, how do we express these feelings really healthily? I understand you're suffering, but how can you make this feel okay? Like, how do we get through today? And how do we do something that's not going to A, end your life, or B, make it so that tomorrow is harder? So I'm very passionate about that. So I'm really just grateful for this conversation, and looking for the future that is for the feelers. It's for the people that can feel all the emotions, but also are seeking out ways that are not damaging to just express and to be. Because the medications, like, I've had my own journey with them, and little things like colors are not as bright when you're on anxiety meds, and it doesn't really matter how long you're on them for, but it takes away the muchness of existence, and it sedates people and they become robotic. And it's really, really sad to see when life was made to be
So
emotional. And
I'm going to ask you a question. So when you lost the idea that something could be robbing you of, I'm just thinking, I guess I use the word robbing because I think sometimes when we don't consider the context, we're robbing people of understanding that they intrinsically might have, but that's being replaced by it's being replaced by another paradigm, another explanation that really doesn't have anything to do with you as a person. So how is it when you're able to kind of see what maybe Rod was talking about, that it wasn't just a construction, right? That you needed to be on medications or not be on medications, but how is it to like surpass that and to be someone that doesn't even think about that in their day-to-day existence?
well, it's phenomenal because I am not thinking in the perspective of I'm being too much or you're not monitoring as much. And there's a lot of restrictions that come with just having those labels of like different mental health diagnoses. So by being able to surpass that and look past that, you're able to identify yourself and see that your feelings are real and you have the power to be able to change them, and you are more empowered and are able to take control of your fate instead of being really just like a passive rock on the shore that's just being slowly turned into sand. You are able to get up and move to what you want to be.
And the things that we can't hit on everything today, but I'd like for us to be able to continue this conversation. But one of the things that I was thinking of is the family members, because as family members also lose that, when the family members lose that sense that this is just a biological entity reacting to other biological components, then the family members, I think, also have there's such a difference for them as well. Would you agree with that, Ashley?
Yeah, there's almost this like desensitization. I don't know why I'm stumbling over my words. Forgive me, I was speaking Italian all morning. But there's this desensitizing that happens with the other individual. Instead of looking at your family member and being like, oh my gosh, you're upset because X, Y, and Z happened, you're more like, oh, you're having a manic episode. Let me distance myself from you and create these barriers and walls and almost treat the house like a prison, which is really not nurturing and not supportive for someone who's suffering.
And we were kind of talking about that last night, of family members becoming kind of jailers, or at the very least like attendees at a hospital in some ways.
Yes, yeah, we were. Because there's this idea of, like, especially in ABA psychology, from what I've read about it and had conversations with my aunt who's currently just graduated from an ABA program, where it's like you have to pull your emotions entirely out of the situation in order to create a really structured environment that is heartless almost. And yeah, it makes it feel like jail. It makes it feel like you're not connected. And that is really what people want, is they want connection, and they want someone to hold them and to journey with them through their emotions. They don't want to be shut in a corner with nothing to look at, told to regulate themselves when they maybe want their mom. Or if you listen to a child crying long enough, they will tell you why they're upset. And
So I'm just going to trade really quickly. I'm thinking about time, and I'm just going to ask Joanna that same question, because Joanna, I've often talked about, like, how do we help the parents? We're helping the clinicians, but also the parents being able to entertain different ideas when they have such a long training of this lack of context.
When the parents have a long training of lack of context,
Mm-hmm. Mm-hmm.
how could you talk to the parents?
Yeah.
Yeah, I mean, I take my time with that question just because my brothers were diagnosed with a lot of different things over the years. And I saw my parents go through the ringer of different psychiatrists, psychologists, therapy programs all over the world, nationally, internationally, and not finding a solution. And at the end, seeing one of my brothers just kind of decide for himself that he's going to improve. And he picked up music, started teaching himself different instruments, writing music, really just changed the way his whole perception of life. And my other brother just continued to want out. Like he'll just say he's waiting for Godot, and he'll smoke like 20 packs of cigarettes a day. He wants to have an exit plan. And I think when I see where my parents struggled, and just how desperate they were for for a solution for their sons, I think what could have helped them was exactly some of the things that we talked about. As somebody giving them hope, somebody appealing to their humanity, planting seeds, and just being with them on the journey. I think that could have really helped them a lot, so they wouldn't feel as isolated, because it is isolating when you have somebody who has these diagnoses. It's isolating for the person, it's isolating for the family. And if they had some of those, good, we're at the end of the day, as a therapist, we're called to be good people in the lives of the people that we work with. And I think if they had a therapist that was listening to them compassionately and giving them hope, it would have helped them a lot. So, but it is a challenge. I've seen, some parents that one agrees with some of the things that we're discussing, and the other parent doesn't agree with some of the things that we're discussing. And then you're adding more conflict to what's already a difficult situation. But if we go back to our role as being good people, it's being with them in that journey. So I think that's how I would answer that question.
Because these are hard. I think these are all hard questions of, Gianna, I have talked about this before, of what are the next steps, right? So you talk about these things, but where is the plan of action? What are, like, that even though things eventually, hopefully, will have a different type of understanding for more of a majority in the field, it's hard, I think, for those waiting for that majority to happen. Like you were kind of talking a little bit, Rod, of it. There's this anxiety of wanting change to occur rapidly.
I'm just thinking back about the question you raised with the family, because that is so absurdly relevant. Because they are easy targets for quick fixes, right? Please bring my son back. Please bring my wife back. And most people are not wanting to hear, okay, this is going to be a journey. There will be no quick fixes. This is going to be arduous. Is going to be tough. And it's still the best plan we have. We have something new happening. Okay, there's this acute phase where we should be worried about predictability, maybe safety and things like that. But in the long run, we are no longer in control. And I think it's very easy. It's very easy to suppress the individual on account of the benefit of the group, which is, for the most part, what psychiatry is very good at doing. And I think, keep in mind that talking to adults, at least, the patient is, or the client, whatever we decide to call these days, which is irrelevant for me, is the target. Their experience is the target of this. Is the focus of this whole thing. This is their experience, is why we are all here talking today. While the family may be happy enough with what we call negative symptoms of schizophrenia, or that are exacerbated by antipsychotics, for example, right? I don't mind that my son is laying down in his room staring the ceiling all day long. It's better than what he was doing last week when he broke in. God knows what was going on. So it's very tempting to say, yeah, let's try to bring some peace in this. And maybe acutely, maybe initially, maybe that's where psychiatry could have a role. And then, but yeah, must be awfully painful for a family member to say, oh, what you're saying is that this is going to be a long and winding road, and we don't know where it's going to be. No, and at the end, you may not like the new version of your child.
Just to interject on my story, Rod, it was long and winding for my parents, but I don't think it needed to be. I think they got kind of distracted by all the things that were getting thrown at them and all the rabbit holes they were chasing, when it could have been a little bit simpler for them. And unfortunately, they didn't have Google when all these things were happening, and they couldn't find your podcast or Dr. Swim. So, but it could have been a little bit shortened. Just
I don't want us to behave as if, because what I fear for these conversations is that it's very easy for us to talk, to adopt a professional tone, and suggest that there are no failures, and there are failures in the sense of, well, I want to use the word failure, okay? That there are no roads that end in undesirable ways, even if we have a very accepting view of experiences. Even, we're not trying to bring anyone back to living a life that conforms with. No, that's not the goal. Even for us, we're gonna feel overwhelmed by things. We're gonna try to partner with a human being and walk the path, and that person's going to say no thanks to you too, and react to it. I was asked this question today. Okay, how do you cope with aggressiveness? Can I say for sure, oh, I can always reach a person and relate to that person and prevent someone or hurting himself or another or somebody else. And that's where, so maybe, maybe we should call that a failure. I'm not sure if we should call that a failure or a step in the process, where when are we going? But I just don't want to sound like there is a simple path and we all have the answer. No, what I'm trying to say is that the simplicity with which mental health care in America, at least, has been addressing these problems is it's contributing to the problem. But that doesn't mean that embracing complexity will always be the solution, because the complexity is beyond what we can handle frequently. We are really talking about the human experience, and we do have the cases where once they stop chasing their tails, things kind of settle down. Like patient that is hearing voices, for example, and have all this sort of a recurrent obsessive delusion, so to speak. Eventually he says, you know what, I'm comfortable with it now. Great, but that doesn't happen all the time. But what I know is that I'm sure I'm not hurting you more, first of all, and we're trying to let you live the experience. But I'm very tactful with this conversation. I remember I was inviting this guy for an interview, and he's the head of the Hearing Voices movement here in Rhode Island, and a very intelligent fellow. And I was talking to him about it, and he said, Rod, I don't know if I'm going to help you in your podcast, because for me, for his case, taking an antipsychotic allows me to live my life. That is his story. You know what I mean? So, and another interesting question I had for a guy that I admired tremendously, that is Dr. Bellmaker, I said, do you think it's time for a new paradigm? Because this is what I do, right? I came up with a new paradigm of work in the field. And I said, do you think it's time for a new paradigm? And he gave me this answer that I'm still dizzy. He said, Rod, I have done enough analysis that I don't need a paradigm to work. In other words, there's someone in front of you. Yalom said the same thing. He said, listen, right? See what they have to say. There's no guarantee, but it's by far a better approach than what we have right now, of what most of us are doing in the field.
And that gets to a whole another conversation. We're going to wrap this up because it's really late where you are, but and I hope that we can revisit this, but this is a journey. As a journey, people have, like, life does not go from being really hard to really easy in just one step, or the same step for everybody. And you had talked about listening. I used to train clinicians to listen, because it's hard to listen, because we have all of these other paradigms that are preventing us from being able to listen. And one of my mentors, his name was Tom Anderson, he was a psychiatrist from Norway. At the end of each session, he would ask a question that would be something like this: if we had this time to do over again, and perhaps we were going to talk about something different, was there something different that we might have talked about that would have been a benefit to you? And so by that, he was able, and I mean, he probably asked it completely different, or maybe asked it different each time, but it gives us kind of a pathway to see if we're even listening, because it's so easy not to listen to people and just to listen to your own ideas of what we want to heartfelt do to bring about relief in the person that's in front of us. And I did do some research with a colleague of mine in Mexico that has an institute, and we called it How to Achieve a Listening Mind for Practitioners, because it's we're taught not to listen, basically, not to only avoid the context, but not to listen as well. And yes, there are times that, of course, that I was talking to one of my clients, and he was going to come to the conference, and I think he'll come the next time. But his mom was diagnosed with having a severe mental illness disorder when he was a child. So when he started experiencing some quote unquote depression and as a teenager, they just automatically assumed that it was the same thing, the same trajectory that his mom had went down and things like that. Well, he's, on the other side of that, doing well, deciding what schools to go to and all sorts of different things. And, but he tried to share with his mom that he was able to very rapidly get over this psychosis, and, he didn't identify with the psychosis, and he wasn't on the medication. And he tried to share that with a mother who had been suffering for 30 years. And someone said to me recently, and I don't know who it was, but to not be able to place it on a diagnosis is embarrassing. That sometimes that's traumatic, that, oh, you could have just did something different, right? When you tried so hard to regain your life and to stop suffering. So, again, these ideas, aren't fluid, or they are fluid. They're not stagnant, they're alive within the different contexts of what we're talking about. And for me, just talking about these ideas then offers people new ideas. I do not try to say that I have the right ideas, because I know I don't. I'm not that clever. And I loved what you said, Rod, in the conference, is that you couldn't, whatever you said, it was in a wonderful way, but I got the sense that it's their responsibility. Does that make sense? Like, you can't enter into their I loved your thing of entering into their shoes, but you can't enter into their shoes and find a job for them, right? Or do all of these sorts of things, because if you found that job, it surely might not even be the job that they would ever want to have. So you get to say the last word, and then we'll wrap this up, Rod.
No, I just want to thank for the opportunity. It was very enriching, and it gives you the kind of a stamina that the task needs. So like I'm going to have a more exciting day tomorrow in my clinical work thanks to this conversation. It gets you going. I really appreciate the invitation. Thank you so much. Yeah, these words live within me as well and in my heart. So thank you so much. And thank you to Joanna and Ashley. And I hope this is, just one conversation again of many that we're able to have. So I'm just going to stop recording and see. There we go.